everybody, and thank you very much for joining us in the first webinar of the New England Baptist Hospital Sports Medicine Series. We're very, very excited to have you all here today. For those of you who are not familiar with the New England Baptist Hospital, we are the only specialty hospital in the New England area. We're specialized in orthopedic care, and we actually see the largest volume of orthopedic cases in the whole state of Massachusetts. That gives us a really unique level of expertise in everything orthopedic, and that's the reason why we are here today. We want to share this information with you, want to share this knowledge with you, and hopefully you'll come away from this webinar with good tips on how to prevent sports-related injuries, and also with knowledge about treatment options if you do have some sport-related injuries. The agenda for today, we're going to have a 20-minute presentation by Dr. Miller, and then we're going to have 10 minutes of a Q&A with the doctor as well. So feel free to send your questions via the chat. That's on the right-hand side corner of your screen in the control panel, and we'll be collecting all the questions, and then at the end of the session we'll try to answer as many as possible. So the topic for today, as you all know, is that fear, dreaded knee injury that can happen to professional athletes as well as to the casual athletes. And we're very lucky and very excited to have with us today Dr. Suzanne Miller. She's a board-certified orthopedic surgeon here at the Baptist Hospital. She's also an assistant clinical professor at the Tufts University School of Medicine. She completed her medical school at the Mount Sinai School of Medicine in New York, and she also has a fellowship from the University of Pittsburgh. In addition to that, she has a master's degree from Columbia University in exercise physiology. Dr. Miller has researched extensively and published extensively around sports-related injuries, and we're very, very lucky to have her here with us today. With no further ado, here's Dr. Suzanne Miller.
Thank you for that introduction, and thank you all for taking time out of your day to listen to this. Hopefully it'll be valuable for you. So today's focus is going to be on common knee injuries. So there are a lot of injuries. We have 20 minutes. I'm going to try to hone it down essentially into talking about two fairly common problems that happen in really across all age categories. One is a ligament tear called the anterior cruciate ligament, and the other common thing that happens is meniscus tears. Now, of course, we can have cartilage injuries to the knee, we can have injuries to other ligaments, but again, just to narrow down for the 20 minutes, we'll focus on these two areas. So what is the ACL? You hear professional athletes, Tom Brady, he tore his ACL. What is it? Well, the ACL, it stands for anterior cruciate ligament, and it's one of the four major ligaments in the knee. So what's a ligament? Well, a ligament is a strong, dense piece of connective tissue that attaches a bone to a bone. So this is, for example, is the ACL ligament right in the middle of this knee right here. And what the ACL does, it actually provides frontal support and rotational stability to your knee, so your knee doesn't give way. Now, it gets help from other ligaments, the PCL, and a ligament on the inside, the MCL, and a ligament on the outside called the LCL. But this is the one that we commonly hear about, and it's probably one of the most commonly injured ones. So how common are ACL injuries? Well, there's about 250,000 ACL tears per year. That's a lot. So it's a big impact on the person. It's a big financial impact. It's a big sort of emotional impact. It's a big deal. There are about 150,000 ACL reconstructions done per year, so surgeries for that problem. And about 50% of people with ACL tears also have tears of the meniscus. So again, just looking at the prevalence of these injuries, this is just a series of athletes, the Big Ten, the Pac-10, the ACC, and the combined data. Actually, you see men have about a 2.2% incidence, and the women about a 16.1%. So you can see how much more common this is in women than men, and we'll get into some of those potential reasons later on in the talk. So how do ACL tears occur? Well, about 70% of them are non-contact injuries. That means it's not a collision type thing where you bang into another player or you don't hit into something. It's usually you're running or doing some type of movement and you decelerate, so you're slowing down, or you're pivoting on the knee, you're trying to turn direction. And again, because the ACL ligament provides that rotational stability, when you pivot, it can pop. And again, girls are 4 times more likely to tear their ACL than men. So what is the meniscus? We spoke briefly before about the meniscus being a problem also with ACL tears. Well, the meniscus can also tear in isolation. So the meniscus is actually a soft cartilage pad that sits in between the top bone, which is a femur, and the bottom bone, which is a tibia. And there are 2 meniscus in the knee. There's one called the lateral meniscus. This is the outside of the knee. And then there's a medial meniscus, which is the inside of the knee. And the meniscus are very susceptible to injury because there are shock absorbers. And they actually, unfortunately, have a poor blood supply, except in the very periphery of the meniscus, which is why, for the majority of times, when these tear, they typically do not heal on their own. So how do meniscus injuries occur? Well, like we spoke about, they can occur in conjunction with an ACL tear. And in a young person, they typically occur, it's typically a fairly extensive mechanism that causes to tear. So typically a twisting motion to the knee, and it has to involve some significant trauma to the knee. So here you can see a picture. This is an inside picture looking in someone's joint with a camera. It's called an arthroscopy. And we can see here the cartilage on the femur on the top and the cartilage on the tibia. And this meniscus is this little cartilage pad, and it's not where it's supposed to be. It's supposed to be back over here. And this is just another picture of a displaced piece of meniscus. So you can imagine if someone's walking around and they can get symptoms of catching and clicking, and that can be quite problematic. In an older age population, we typically get what's called degenerative tears. So what happens is the top bone, again, the femur, starts wearing away. And you can see here, here's normal cartilage. So this is, again, looking at a picture inside somebody's knee where it's nice and smooth, it looks like an eggshell. And then this is all bumpy. So you can imagine how if you're walking, this bumpy sandpaper type surface can cause some degenerative tearing to the meniscus below it because it's constantly rubbing. And usually these type of tears are associated with fairly minor trauma. Someone could just describe getting up from a seated position and then all of a sudden their knee swells and they get diagnosed with a meniscus tear. So as opposed to the younger person, which usually requires some significant trauma. So moving back into ACLs, what is the treatment for an ACL injury? Well, it's typically a surgical problem. Non-surgical treatment for ACL tears is fairly poor option in a young, active, healthy patient. And again, I say young. Young's a difficult thing to define. So there are people in their 50s that I would consider young. There are people in their 60s that I would even consider young. So it's really about the patient. It's about what the rest of the joint surface looks like and their activity level. Now, over time, without surgery, and one of the reasons to do surgery is that 90% of people with ACL tears in isolation will develop meniscus tears down the road because the joint, because that ligament is gone, the joint is now not moving congruently, and it puts extra stress on that meniscus. The meniscus acts as a secondary stabilizer to the knee, which is now going to be very much stressed without an ACL. And 70% will develop articular cartilage defects within 10 years without surgery. So you can see here, this is what we call an articular cartilage defect. So normally the bone has this nice smooth cartilage on it like the end of a chicken bone, nice eggshell, and this is a cartilage defect. This is actually exposed bone. So you can see here the cartilage came right up off, and that's a big problem because like the meniscus having a poor blood supply, the cartilage, hard cartilage surfaces also have a very poor blood supply and are not amenable to heal. So surgeries, it's typically a very good option in a young active patient. There's about a 75 to 90% success rate for obtaining a stable knee. However, there is only about a 60 to 65% chance to return to play at the same level. So can most people get back to sporting activity? Yes, most people can. Can they necessarily, and this is, comes into play a little bit more for your collegiate or your professional athlete, can they get back at that same prior level? And that's where it becomes a little bit more difficult. But for the average recreational athlete, you can expect a good full return to sport. So what do we do to fix the ACL? If someone tears their ACL, can we just sew the ends back together? Well, we can't, unfortunately. The ACL sits in the middle of the knee joint, and in that joint is what we call synovial fluid that keeps everything lubricated. So when that ligament tears, it's like 2 mop ends in a bucket. It really it's not a straight thing that we can just sew back together. So we actually have to reconstruct it. We have to make a new ACL out of something else. And we can use something called an autograft, which is taking something from your body. Either a hamstring tendon is very common, or a patella tendon is very common, or we can use something called an allograft, taking something from a cadaver, someone that's passed away and has donated their tendons and ligaments for use. So again, the way we construct the ACL is we actually string a new ligament across the knee, and we typically use a screw or a button to fasten it on this side and typically on the top side as well. And this is a picture of an ACL reconstruction. So this is a new ligament that was placed across the knee to replace the old ligament. How do we fix the meniscus? If the meniscus is torn, it needs to be dealt with at the same time as the ACL, or if someone just has an isolated meniscus tear, how do we treat that? Well, it depends on the location of the tear, and it depends on the patient's age. Like previously stated, the meniscus on the periphery here has a good blood supply. So we see all these vasculature and all these vessels. And blood supply is important for healing. Without good blood supply, you can't heal. So sometimes if you get a very clean tear in the periphery of the meniscus, you can actually put some stitches across it and sew it. Once the tears come into the middle part of the meniscus and in the very central part of the meniscus, the blood supply is not good, and unfortunately, once they tear, we do have to clip out the unstable portion of the meniscus in order to get people to have good pain relief. So again, this is just a picture. I'm depicting a tear here in the periphery. So here's one in the periphery, and that would be amenable to stitching. Here's one in the central part where it's not amenable to stitching, and we just make a smooth surface and clip out that meniscus tear. So after ACL reconstruction, how do we rehabilitate? Typically about 6 to 12 months of rehabilitation is required. And this has big implications. There's missed playing time, there's decreased performance, it's a financial burden, and it can really cause some disruption in families. One study did show that over 5 years, this NFL showed 79% return to play. However, like we spoke about, at the same level, not quite. There was about a third reduction in performance with running backs and wide receivers. So in the beginning of the slide, we saw that women or girls are much more at high risk for this injury than boys. And we want to try to look at why, because it's an epidemic, it's a problem. Well, there's certain non-modifiable risk factors. One is anatomic. So we look at what's called the notch width, and that's where the ACL sits inside the knee. And if the notch is narrowed, we think that puts extra stress potentially across the ACL. But we can't do anything about it. You're born with a certain bone shape, and that's who you are. Same thing with hormones. There's some hormonal evidence that estrogen can actually affect ACL elasticity, and there's some studies that suggest that you're at higher risk at different points in the menstrual cycle. But again, we can't do a lot about that because we are who we are. Then there's other modifiable risk factors. We can look at environment. Is it worse on turf? Is it worse on, with year-round play? Do shoes make a difference? And there's really not a huge consensus on this. And then there's neuromuscular, and this is actually the major risk factor that we have found to be something that we can modify and do something about. So I'm going to spend a few minutes speaking about this. So what does it mean? What does neuromuscular mean? Well, it means how your body is reacting to ground forces, how your muscles are reacting when it hits the ground. And people who are at higher risk for ACLs tend to land more upright. So if they jump off of something or they jump up and turn to pivot, they tend not to bend their knee. They tend to land more upright, and it's called quad dominant. They use their quadriceps, which is the muscles on the front of the leg, as opposed to their hamstrings. And by landing in this position, it actually puts a lot of stress on the ACL. So when they run and they turn or they pivot or they decelerate, like we spoke about, they're actually not bending quite enough. They're not recruiting their hamstrings enough, and it puts extra stress on the ACL, and then it pops. And there's actually a position of vulnerability that we talk about, where normally to have a good, strong knee and a good sort of mechanism for running and cutting and pivoting, you want the knee to be a little bit flexed. You want neutral alignment, both feet. The position of vulnerability is this one, where the knee kind of is not bent. It's usually extended or sometimes even hyperextended. It's in what we call valgus, so it's moving towards the outside a little bit. and the foot is out of control. And when the leg gets into this position, that puts untoward rotational stress on the ACL. So again, you can just see here, we look at, these are two women here, and they're just doing simple jumping exercises. And we can see here, this is preferred. So she's landing with her knee semi-flexed, nice on a bent knee, and that's good for her ACL. This kind of business, this is terrible. This causes rotational torque on the ACL, and it puts someone at high risk. Again, this is just showing also bad here, top picture A, it's going in what we call valgus. No, a lot of stress on the ACL. This is good. She's coming down, her knees are straight, she's recruiting all her muscles appropriately. And another thing that we think is also a risk factor is a weak core. There's a lot of emphasis now on core training and planks and do all that. Well, we're a big kinetic chain. So if you don't have a strong core, you're going to put untoward stress onto your knee as well. So we think that working on your core is just as important even than working on your knee to try to prevent ACL injuries. So can you predict an ACL injury? Well, you can a little bit. If you see somebody who is in that position of vulnerability, who has their leg collapsed in and is not moving correctly during sport, well, that person's at risk. And we can actually, and we've looked at studies and trying to see if you can predict it. And we looked at women beforehand and how they landed, and we actually did, you can do 3D kinematic studies and see, and you can see the ones that land wrong as opposed to right are at higher risk. There's a higher incidence of ACL tears. So we can actually, again, just more pictures showing, here's good, she's got her leg nice and straight, bending nice and straight, terrible. She has no control over her gluteus, which is another muscle. Her leg is going into that outward position. She has no control. You can see how she's just torquing right across the knee. This is a setup right here for an ACL injury. So there are a lot of things actually that we can do to prevent this neuromuscular problem. Time off from sport is very important. So the trend these days, good or bad, is to somehow get, especially with younger kids, we're seeing it more often, to be involved in the same sport year round. Well, cross-training is really important to increase balance and strength, work on the core, and it improves in performance. General strength, stretching and strengthening program is also good. And then there's specific neuromuscular training. And there's a lot of different neuromuscular training programs around. There's one called PEP, which stands for Prevent Injury, Enhance Performance. There's also a program out of Cincinnati called Sports Metrics. And they've actually looked at these programs and how effective they are at preventing ACL injuries. And they actually are very effective, about a 20 to 80% reduction rate in ACL tears. Now, where the biggest challenge is really trying to get coaches and people who are dealing with these athletes, as well as recreational athletes, to engage in these programs, because even though it only takes about 15-20 minutes a few times a week, that's taking away from generalized practice time. So an ideal functional training program should contain stretching, strengthening, core exercises, plyometrics, agility, education, verbal feedback, so that knee looks good, or you look good there, or you don't look good. And then timing, again, 10 to 20 minutes, 3 times a week preseason, and even 1 time a week in season has been shown to help. So what's important is to cross-train, educate yourself, parents, coaches, teammates, and perform a well-structured ACL prevention program. Because if you can even prevent 1 ACL injury, that's a huge, huge burden. That's uplifted. It's a big impact in someone's life. Thank you. Happy to take any questions that anybody has regarding this dreaded knee injury, and I hope that was informative for you.
It was a great talk. Thank you very much, Dr. Miller. We do have a few questions that we got from the audience, and we're going to take a few minutes to answer. I think we have probably around 5 minutes. So the first one, and I think you touched on it a little bit, is can you re-injure your ACL once you have it reconstructed after treatment?
Unfortunately, you can. So although the results are very good, there is probably about a 5 to 10% incidence of re-injury of that ACL ligament. And again, it depends on who the person is that has it reconstructed. It depends what sports they're engaging in and how much of a high-risk activity they're doing. Obviously, a contact or collision sport is probably at a higher risk than your generalized recreational athlete.
Okay, great. When can you return to full sports after an ACL surgery?
Most people are able to return to the majority of sports in and around 6 months, and that can vary depending on the sport, depending on the level of play of the athlete. So although timing is important, because we know that biology has to take place and that ligament has to incorporate into the knee, we actually really think that functional training, seeing how a person looks, you have to actually simulate things that they're going to do. Are they able to keep their knee in that safety position, semi-flexed? Are they able to sort of simulate whatever, say it's basketball? Are they able to jump and come down and land appropriately? So we actually go through a series of this testing before we allow athletes to go back to sport.
Okay, thank you very much. Our next question, someone looking for more conservative treatment. Can the ACL heal on its own, or you do have to have surgery if you tear it?
So that's always tough. So the ACL unfortunately does not heal on its own. Like it's bathed in synovial fluid in the middle of the knee. So when it tears, it's sort of just like two mop ends that roll out, and it does not heal on its own.
Okay. And can a meniscus tear heal on its own?
Not typically. Occasionally a small meniscus tear in the periphery where I showed that there was a good blood supply. Sometimes that can scar in and heal on its own, but the majority of degenerative meniscus tears or central or middle meniscus tears have no capacity to heal on their own.
Okay. Well, thank you very much. This is great information. Well, this concludes the first webinar of our sports medicine series. We want to thank Dr. Miller for an excellent presentation and for sharing all this great information with us. So we hope that all of you found some good tips and good information to prevent sport injuries or again, to have more knowledge if you have an injury and you are looking for a treatment option.